Okay, welcome everyone to our conference today. As most of you who are regulars know, over the summer we tend to have our conferences on a more intermittent basis. But when people with interesting things to say pass through town, we can't pass up the opportunity to have them enlighten us, you and us. And this conference is also one of the what we're calling IDL talks related to the Informatics Discovery Lab. That's an initiative in the department that's trying to be more engaging with the outside world. And so we've invited today some folks from a company called Modal. It turns out actually that OHSU is one of their clients on the operations side, and we're engaging with them in conversations more on the academic side. The speaker today is John Handler, I guess. And are all you guys? Or
we do everything together.
You do everything together. That's great. Okay, well, I only have biographical information on... Okay, he can introduce them. Okay, and it's kind of fun for me to introduce John because he and I actually, a few years apart, I won't say who's older, unfortunately, but followed a kind of somewhat similar path through life of going to high school in the northern suburbs of Chicago, doing undergraduate work at the out in the cornfields at University of Illinois, Champaign-Urbana, and going to medical school at University of Illinois, Chicago. He then went off and did residency in emergency medicine at George Washington University, and then came back to the Chicago area where he was at Northwestern University for a number of years, actually started informatics activities there. And then went into the private sector. Well, I guess it wasn't the private sector initially, but with the MedStar health system in I'll let him tell the whole story because I'll probably get it wrong. But some of you may be familiar with the Microsoft product called the Zixi that he was involved with developing. Well, actually, it was developed at MedStar, then Microsoft acquired it. And then John moved on about a year ago to Modal, where he's the Chief Medical Informatics Officer. So I won't mangle his history any further. I'll just turn it over to him.
My thing working. My history is boring, so I won't do any more than what you already heard. Other than if that Zixi word sounds weird, Microsoft renamed it shortly after we got there to Amalga. So if you've heard of Amalga, that's the other word for Zixi. So I'm going to talk to you a little bit about my experiences in what I'm calling creating magic, aspirationally anyway, which is what it feels like when you have a really, really great user experience in something that you've created. And you know, the problem with user experience stuff is that you talk about it and everyone rolls their eyes, oh, that's so obvious, it's common sense. And then you go out in the world and you see that all these really smart people have created stuff that appears to be written by people or designed by people who must have no common sense because it doesn't work at all. And so what I'm hoping is to give a set of principles that that we've followed or identified through many mistakes along the way. We were apparently just as bad as everybody else at designing these things, but we were smart enough to at least learn from those mistakes, trip and fall, get back up, and do better. And why should you have to go through tripping and falling? And you know, maybe you can learn from some of our mistakes and some of the things that we actually managed to get right eventually. And so I'm going to talk about some of the principles that we used to create things that felt like magic to us and to some of our end users when we built them. And then I'm going to turn it over to Lynn Koseki, who is our Director of Solutions Realization at Modal, and Dan Engel, who is our Team Lead and Senior Solutions Analyst at Modal, to talk about how we actually go about and harvest new ideas through our Lighthouse program. So we'll take the principles, and then how do you then go ahead and apply them in order to harvest these things and create cool new things that your constituents can use and get value from. So with that, I'm going to zip through this. If I go too fast or you miss something, please let me know. So I'm going to go fast. This is Northwestern's emergency department. This is where I worked for 10 years. I saw patients. It's a level 1 trauma center. We had an increase in volume. As you probably know, most emergency departments are overcrowded. We were in the heart of downtown Chicago. We opened up a new hospital, and so we had, almost a 50% increase in volume. And this is not just, people coming in with, I have a hangnail. These are actual pictures of our people working in our emergency department. Super duper busy. Gunshot wounds and stab wounds and people in car accidents and heart attacks. And also I cut my finger and I cut my face and I got beat up and all this other stuff. And so when we would see a patient, we would have to write up the chart. This is actually a chart I wrote up. Paper chart. Yeah, it's hard to read, but, blame the medical student. The medical student or the resident did most of the work. In 1995, this was all I had to write. This is another chart that I wrote up in the year 2000. Every single word on this chart, because of changes in regulations about who's allowed to document what and how much you have to document, every single word on this chart was written by me. Big difference. And guess what? That's page 1 of 2. So double that, right? And so what we found was because we're having all these increasing patients and all these increasing requirements about all this work that I had to do, and I had to do all the documentation, I had to do all this stuff, and I have to check this box for this and check this box for that, and do this billing code here and do this billing code there. My work required of me was going way, way, way up at the same time that more and more patients were coming in, and the time available to do that work was going down, 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 down. So what I realized was that time is really a zero-sum game. A zero-by-zero-sum game, I mean, if you ask me to do some task, then I got to subtract one. There's no more time to steal from. So if Bill says, John, I've got a super new, awesome thing. It will really help us down the road in terms of creating great patient care. I need you to check this box. And then all this good stuff will happen. Well, if checking that box doesn't save me time, then I have to stop doing something else in order to check Bill's box. So that means my choice is going to come down and click your new checkbox, Bill, or give aspirin to the heart attack patient. And which one do you think is going to win? Right? And you think I may be exaggerating, but I'm actually not. We put in an EHR at Northwestern. This is a screenshot of the screen that all the stuff you have to enter just to document one allergy. So it used to be, you're allergic to penicillin, I wrote down penicillin. Now I have to do all this stuff just to document penicillin. And so as a result, clinicians at our institution and almost every other one I've been to have become skeptical of technology, and rightly so. This is how it feels when the chief medical information officer comes to the hospital and says to the clinicians, we've got some new technology for you. I promise it'll be really good. That's what they feel like, and they're right. So we moved into a new emergency department in the year 2000, and it was a block long, really, really complex, a whole bunch of different parts. We did not have any tracking system to know where our patients were or what was wrong with them or what's going on. We didn't even have a grease board, which if you've ever worked in an emergency department is like insanity. And now try and do that in an emergency department that's a block long, and while we could do it in the old one, in the new one it just wasn't working. When the patient's family member called up and said, "Where's my mom, Mrs. Smith?" Literally, the nurse or the doctor, the secretary had to go to room 1 and go, "Are you Mrs. Smith?" And then go to room 2, "Are you Mrs. Smith?" And then go all over the emergency department, a block long, trying to find out where the heck is Mrs. Smith. So our nurses said, "This is insane. We can't function this way. We're going to make our own tracking system." And they did. They actually created an Excel spreadsheet that sort of looked like the shape of our emergency department. And every single time a patient came in, they erased what was there before, and they would type over the new one. Oh, it's a Mrs. Smith with epigastric pain, and at least they solved the problem. And I said, well, okay, if you're going to go do that, I mean, I could do something better than that. So I wrote a tracking system for our emergency department, and at least you wouldn't have to erase everything, and we would save it, and we could do all sorts of work on it. And I got a feed from the registration system, so we could auto-populate all sorts of data. So they got all the same benefit. And they did a whole lot less work, and they were really, really happy with it. I had the view that was sort of the geographic view, and then this is a tabular view. And the rollout for this tracking system, you've all heard probably that when you go to roll out a new system, you need to get champions and buy-in and all this other stuff. My rollout was 1 minute. So I wrote the tracking system, I went downstairs, and I said to the triage nurse I was working, "Here, here's your new tracking system if you want it. I don't care if you use it. Click here, and this thing pops up, and you can say what their triage score is. Click here, and you can change the room. Okay, that's it. If you choose to use it, go ahead. If you don't want to use it, I really don't care. And that's what ran our emergency department for the next 5 years, and that was the sum total of our rollout. So I got pretty cocky. I thought, wow, I am amazing. I can do anything. Everyone else has all these problems, and I'm such a great designer that, I made this great system. So then the SARS outbreak happened. How many of you guys have heard of SARS? Okay, so pretty much everybody, mostly in Toronto and China, but spreading to some other countries as well. The people that were mostly dying were healthcare givers, right? So someone would come into the healthcare environment, they'd infect the healthcare giver, and then the healthcare giver would die. So we were being disproportionately affected. I'm in the heart of downtown Chicago, the Magnificent Mile. If you are a visitor from Chicago, coming to Chicago, and you can imagine plenty of people from Asia and Toronto and Canada were coming into Chicago, and you get sick, you're going to come to us. 95% likelihood. If you're sick in the Chicago area, you're going to come to us. If you're in the downtown area, and so our nurses were completely freaked out. We're going to die. You've got to do something. And so they said they wanted a SARS screening tool. They wanted a way to check in my tracking system, check for SARS. And so I said, no, you're never going to use it. And they said, yes, we will. You don't understand. We're the ones at risk here. Stop being so selfish. You got to make something to help us. So I said, fine. You promise to use it? They said, yes. So I did. So I did everything they said you're supposed to do. This is the tracking. This is the thing that the screen you'd go to. These fields would be auto-entered, and then you just had to enter the triage category and the location, right? And they could enter this stuff if they wanted to. I added this third box. On the screen they were already going to every single day on every single patient when they did triage. And if you look at that box, it's my SARS screening tool. The way I designed it, there was only a few questions to ask in total. And the way I designed it, the first question was, did the patient have a fever of 100.4? If not, click no. You don't have to answer any of the other questions. Literally a one-click start to the screening, and one click was all you needed for the majority of the patients. So I followed all the best practices that all the informatics experts say you're supposed to do. Get buy-in. Well, I didn't need buy-in. Heck, they put me in a headlock and forced me to make the thing. Get a champion. Yes, the nurses were all over it. Build it right into the workflow. Well, I absolutely did. Right on the page you were using every single day, minimal additional work. It was literally one click, and the end users have to benefit from it, which they did. Supposedly they would avoid SARS as a result of this. So now I have a quiz for the group. It was one click to screen for SARS. In a week, I went back and looked to see how many patient visits did the triage nurse who was already on that screen do the one click to screen for SARS? What percentage? 30, 10, 0, 8, yes? 2, 5. Okay. 100, that would be excellent. This is the actual graph. 1%. 1% of the cases. Okay, well, so now you might be saying, well, but John, they're not going to... SARS presents with fever and respiratory complaints. Maybe you got so few patients because, you're including all comers, right? If somebody comes in with a finger laceration, well, we wouldn't expect them to screen for SARS necessarily. So I said, fine, let's take a look. For the patients who came in where their chief complaint was a respiratory complaint, so now you really would actually be worried about SARS, what percent of patients with a respiratory complaint had that one button checked? 5. The answer, not one. Not one. Okay, fever patients. The question was, does the patient have a temperature over 100.4, a fever? For the patients whose chief complaint was, I have a fever, how often did the nurse check, yes, the patient has a fever, or no, if for some reason it was wrong? Percentage? Okay, now you guys are learning. Not one patient. Okay, so who did we ask about SARS? This is the list. Not many people on the list. A patient in a car accident, and somebody was beat up by a bouncer. So, we were the few times we actually asked it, it probably wasn't even worth it to bother. Yes.
One question is, if the system already knows what the temperature is, why even ask?
So I was hoping somebody might ask that question, and that will be a future part of what we talk about. But we only knew that there was a complaint of fever, and you're right, I could have auto-defaulted that in there. Then the next question would be, if I didn't ask, they would then drop down to the next question, and what do you think is the likelihood they would answer that question? And the answer is basically, as you've seen, it's going to be in the rate of 0 to 1%. And that's the main lesson that I learned out of this thing, which was, how did this happen, right? Why did I have such a big success on one thing and such a big failure on the other? Well, this is the situation here, right? Here's the nurse treating this patient. They're doing triage, let's say. Who benefits when this patient was breathing SARS all over this triage nurse? Now, who benefits if she documents that this patient is at SARS risk? Not her. Too late. She's already going to die, right? So bottom line is, if you're not the direct beneficiary, people aren't going to do the click. And how many patients in the end actually had SARS? 0. Sorry. 0 actually ended up having SARS. It turns out that we'd have been a whole lot more appropriately concerned if we were worried about tuberculosis, meningitis, the things that actually do come into the emergency department, not the thing that's showing up in the newspaper that day. So what I learned is this. End users will not do even one click, not one single extra click, if it does not immediately save them time every single time they do that click. So every single time I have watched an informatics effort or a technology effort or a process improvement effort go astray, I watch all the logic about why people will do it. Well, this is good for patient care, so they will do it. How many people, what percentage of the time do doctors not wash their hands before going in to see a patient? 30%, minimum, every single study that's ever been done. We've known since the 1800s that drops the rate of death dramatically, right? If doctors won't wash their hands, and caregivers won't wash their hands before they go in to see a patient, what makes you think they're going to click your checkbox? Your checkbox can't even compare to the value you're doing to patient care compared to washing hands, and that's already a losing proposition. So the trick to creating magic, in 2 words, don't fool yourself that it is anything else, in user experiences, is save time. You give somebody something and it saves time, you won't be able to stop them from doing it. You give something to somebody that goes the other direction, even one click in the other direction, and it costs them time, you will spend your whole life beating your head against the wall complaining about how nobody is doing this thing. And that is, if I was going to give you one lesson for today, you don't have to agree with it, but I obviously will. You can pay people to do things that will cost them time, but you can almost never get the keep that up, right? I'm sure Bill could get me to click on that checkbox he wants me to click if he pays me $10 every single time I click it. But what he's going to do is he's going to say, I'll pay you $10 for the first 3 months. And as soon as the $10 goes away, I'm not clicking it anymore. That's what really happens. And that's why 60% of projects fail in the real world. They go out there, they put all these people, and they convince you that you should do it, and then you go away, and then 60% of the time, once you go away and you take all that extra energy you're putting into it back out of the system again, they fall back to the original state. So what is the trick to saving time? Again, in 2 words, my answer to that is automate everything. So the rest of everything I'm going to talk about is how do you automate everything? And I'll give as many examples as I can. First of all, there's no point in automating anything if the automation itself is going to take so long it's going to upset people. So you got to turbocharge your systems. It doesn't matter if the thing will automatically log you in and automatically do everything for you if you're just sitting there waiting 10 minutes for the wait cursor to go, right? So that's the number one thing you've got to get rid of, no wait cursors. In fact, we've actually known this since 1968. Robert J. Miller presented at the 1968 Fall Joint Computer Conference a study on what users' perceptions are for speed of response when you click on something in a computer program. So if you have a speed of response of less than a tenth of a second, to the user it feels like that was instantaneous. If you go past a second, now the user's thoughts start to drift. You start thinking about something else. Hey, I wonder what I'm going to eat for lunch today, blah, 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 blah. As soon as that happens, as soon as their thoughts go from the task they're on to something else, the rate of errors skyrockets, and there's a ton of studies about that. And then heaven forbid you wait 10 seconds. The user will actually turn away from the task they're doing and go do some other task while your wait cursor is spinning. And in a significant percentage of the time, as much as 10 to 30% of the time, they never turn back to the original task that they were doing. That is how things get forgotten. I was going to order that aspirin, but then I turned and did something else while I was waiting for the system to go, and then I forgot to order the aspirin. So this is the targets you got to set, right? It's really pretty much 1 second. You want to make a great system. When somebody clicks on something, it shouldn't take more than a second for it to respond. That's hard to do. So how do you turbocharge it? Well, you may not. This is getting old geeky. You may not get involved in this, but first of all, buy better computers and put in faster networks. Nobody ever wants to do that because it's expensive, but guess what? That's the cost of doing business. Tune the database, write more efficient code, and then we talked a lot about early binding. Pre-calculated ingestion. So for example, this is like a super secret trick I've done 1 million times, and it looks afterwards like I walked in and I was some super genius, but when I told them what I did, then they dismiss it as that was just too easy and I cheated. But cheating is great, right, if it gets you where you need to go. So let's say that every single time I show a patient in my electronic record or whatever system it is that you're working with, I want to show how many times that patient has been to this hospital. So one way to do it is to have one entry in the table for every patient visit, and then John Smith is in here 3 times, and then a whole bunch more. Right? And every single time I go to John Smith, the computer has to go back, go through every single one of the millions of rows in this table and count up how many John Smiths there are. Well, that's going to take a long time. Whereas if at the time I get a new visit, I have a separate table where I just up the count of the patient's visits, then I just have to go to this one row and show that number. Right? And suddenly, I can literally make something 50, 100, or 1,000 times faster. And why am I telling you this? I'm telling you this not because I expect you to go out and go code and do this stuff. I'm telling you this so that you have this expectation of the folks that you work with to say, it is actually possible to make systems that will run in less than a second, and these are some of the ways to do it, and that's just touching the top layer. And I just want to, we get so used to things being bad that we lower our expectations so far that then we don't ask for things that really should be reasonable, right? And I want to up your expectations back up, right? When you click, it should be instant. Okay, how to automate everything. Another thing to do that sort of creates magic is to pre-process everything. So this is the EHR that I had to work with at Northwestern. These are 2 of the columns that would pop up in my list of patients. The admitted date and time, the date of birth. Why do you think they thought it was important to show the date and time of the patient's admission? So that I could see how long the patient has been there. So now what do I have to do? Now I have to go, okay, well, today is this date, and that was the date that they came in, and I have to do a mental subtraction in my head to figure out how long they've been there. Why do you think most of the time they put the date of birth in there? Sometimes it's for identification's sake. But the real reason? Age. So now I've got to figure out, let's see, if they were born in 1959, and my math is really terrible, and it's 2013. Now I have no idea how old they are. Right? That's how you get mistakes. That's how you get users to feel like, I don't know, can't explain why I don't like this system, but it feels bad to me. Right? It turns out that both of these fields were actually in and configurably in the underlying system that I have. It just wasn't configured to show it that way by default. So we turned on a system where actually something good was 1 minute away. But because we didn't actually bother to show the pre-processing, we didn't understand what was the user going to do with this data. Right? They were going to do a calculation for the length of stay. Well, why not just show the length of stay? Pre-process that data and show it right away. That's exactly what I did when I made my tracking system, of course. So when I said the room length of stay, I didn't show the time that they entered the room. I showed how long they've been in the room. I didn't show the time they entered the emergency department. I showed how long they've been in the emergency department. I didn't show their date of birth. I showed their age. I didn't show the date of their last visit. I showed how many days ago it was. I was just pre-processing a whole lot of data, knowing what would I need to be doing with that data and how would I use it. By the way, my wife wants you to know I was not responsible for that misspelling. She thinks, they're going to think you're an idiot, John. You've got to tell them. So when we go to the next step, when you anticipate the user's needs, then they really feel like this thing is amazing and super magical. What is the next step that they're going to need to do? This is my EHR that I had to work with at Northwestern. Here's a patient with a chief complaint of weakness, and when I pulled up their test results, this is what I saw. So now, I don't know why it couldn't calculate the anion gap. All the information's right there. Why it's still pending is beyond me. We'll leave that aside. The glucose is 169, and it's a little bit high. So now I want to know, what's the next thing I want to know? Glucose is a little high. Okay, well, maybe is the patient diabetic would be cool. How about just, is this a normal glucose for this patient, right? You know, even if they are diabetic, is 169 good or bad for them, right? I'd like to see another glucose. Might be related to why the patient is weak. So in order to do that, I actually had to right-click, spend the next 3 minutes clicking, you know, to expand the date range of results a whole lot further. And then all of a sudden, I get all these extra columns and some extra data here. And in order to find out whether or not there was a prior glucose, I have to scroll all the way off to the right. And after doing all that work, I have no idea whether or not I will actually ultimately find the glucose. Also, by the way, now it's elected to show, now that you said you want to see more, a bigger date range, now it's elected to show me that the patients had an MRI of the brain, a nuclear scan of their heart, and a sleep study. Now, for a patient with weakness, do you think something related to their heart, their brain, or their ability to sleep might have something to do with their weakness? Of course, right? So anticipating my needs, the system should have shown me this right off the bat, right? And should show me the glucose right next to one another. So this is that system Izixi that we built. This is one row per patient visit. And what you can see here is I can see at a glance the date. I really should have, instead of used the data, I should have, of course, calculated, and we did this later. I should have said how many days or months or years ago it was. But the date of the last lab, the date of the last x-ray, the date of the last radiology reading, CAT scan, MRI, angiogram. So I could see at a glance that the patient did have, in fact, a lab and how long ago it was. And if I double-click on the lab, what do you think is the next step I'm going to want to do? See the labs. Double-click on the x-ray, I'm into looking at the x-rays. Double-click on the MRI, I'm looking at the MRI. But the best part about this was a blank cell means they never had an MRI. I don't even have to go looking for it now. I don't have to go clicking all over the place. Have they had an MRI? As soon as I see the patient exists, I know if they've had an MRI, if they haven't had an MRI. So I'm actively anticipating their needs. This is that same system. Now we're looking at the lab viewer. You'll notice that I've got tabs, one for each different type of lab. But next to it is a number, right? And that's how many lab tests there's going to be of that kind of lab. So if there's a 0 next to one of these things, I don't have to click on that tab to see if I'm missing any data. In that way, I'm anticipating the user's needs. I'm showing you the labs, so what is the need? You're probably going to want to look at the labs. You're going to want to make sure you haven't missed any labs. So how do I do that? I pull forward, do click here, don't click there, and make that really easy and obvious. Here's the patient's blood glucose. By the way, you'll notice this is what we were talking about before, right? The bedside glucose where they, anyway, with one double click on that, I can see the lifetime history of the patient's glucose is one right next to another. No scrolling around, no digging around. And with one more click, I'm graphing that over time, and I can see that this patient's basically never in glucose control. So all the glucoses are in 300, 400, 200 range. So I already know this patient's a diabetic, and a poorly controlled diabetic at that. Left knee pain. Patient comes, this is in my tracking system, patient comes in with left knee pain. Well, what's the first, one of the things I'm going to want to do as a next step? I'm going to want to see their prior visits. They've ever been here before for knee pain. Well, with one click on the last visit, I actually pull up a list of all their prior visits. The first one shows me arthritis. So now I already have some clue as to why they might have their knee pain. If a patient comes in with a bleeding port, with one, now I'm going to want to know next step. What is their past medical history? With one click on from that very same screen, I can jump into their past diagnoses, and I see that the patient's a hemophiliac, right? And I've actually counted how many times the patient's gotten each one of their diagnoses and pre-processed in ordering, so that you see the most common diagnoses or the most urgent diagnoses up front, and then everything below that. If I treat the patient, I'm in the emergency department, I treat the patient, now I'm going to send them home, or I'm going to admit them to the hospital. What am I going to have to do? I'm going to have to call their doctor, their private doctor, and say, hey, this is what happened in the emergency department. I'm going to send them home now. I need you to follow up. So with one click from there, I can see every patient every doctor that the patient has ever seen according to all the records that we have. Now, as soon as I see that the patient's seen Dr. Tater, what do you think is the next thing I'm going to do? Call up Dr. Tater, that's right. So with one click, I actually linked into the hospital's directory so that now I have the phone number right there. If I'd taken it one step further in the modern world, I'd make one click and I'd be Skyping with them or something like that. Another thing that you rarely see done but is incredibly powerful is the idea of marrying different data types. So if you look at a typical EHR, there's one tab for the problems and one tab for the meds and one tab for the allergies and one tab for the labs. And never the twain shall meet, right? We never put together the lab test with the relevant medications or the lab test with the relevant whatever, medical problems. But when you do marry data types like that, that can be super duper useful. So Bill and I are on a mailing list called AMDIS. It's a bunch of CMIOs and stuff. And there was a big discussion. What is the best way to show culture results? So here's a patient with Pseudomonas aeruginosa, that's a germ growing in their bloodstream, and here's a bunch of antibiotics that they tested to see what antibiotic works for that germ. S is sensitive, meaning the antibiotic works. I is intermediate, meaning it may work, may not. R is resistant, meaning it definitely doesn't work. So then they want to know, what is the best way to show this to drive the right decision making? Should we show the interpretation as one letter? Should we spell out the whole word of the interpretation? Should we emphasize the drugs that work by capitalizing them? Or should we emphasize the drugs that don't work by capitalizing those? And this leads to 300 emails on the top. One of which was mine, which was completely ignored. And that was, hey, we suffered with this problem once. And what we realized is most of these patients are already on an antibiotic by the time the culture result comes back. So what we really want to do is combine the medication we know they're already on some antibiotic, with the sensitivity results that tell us what antibiotic works, and auto-generate some sort of recommendation about how those two combine. So that's exactly what we did. Here you're looking at the organism is MRSA. You're looking at the antibiotic that was tested, oxacillin. The sensitivity is resistant here. And the treating antibiotic, the patient's not on an antibiotic. So I zoomed it up here. And then I went ahead and said, hey, problem, no antibiotic. I add together the lab result with the medication list to combine and give some summary of what that means, and then to order those in order of importance. So the very first ones we put up at the top are, hey, your patient's got an infection and they're not even on an antibiotic. Maybe you should add one. The next one is to say, hey, you've got a patient who is on an antibiotic, but bad news, the antibiotic they're on, the bug is resistant to it. It's not going to work because this is the antibiotic they're on, vancomycin, and this is the sensitivity of vancomycin, which is resistant, right? And so by putting those two things together, it's much more powerful than deciding should I capitalize it or not. It's just saying, what should I do? Keep going with the antibiotic, switch them, or add an antibiotic because there's not one there. This is something that a guy named Dr. Michael Hochstein did in the surgical ICU. He created in our system a device tracker. Every single central line and chest tube and every single Foley catheter, endotracheal tube, every tube or line that was in the patient's body, he would track it here. And then he combined what he knew about the device that's in the body with the culture results. So that if you have a central line sitting in your bloodstream and you have a blood infection, you got a problem. Either the central line is causing the blood infection, in which case you got to pull it, or the blood infection is going to infect that central line, so you got to pull it and switch it. Bottom line is we combine two different data types together in order to create some sort of obvious experiencer instead of making the doctor go ahead and say, well, here's the line, now let's compare the culture, now I'll try and adjudicate the two in my head. We combine those natively and you get this super magical feeling. Changing modalities gets pretty cool. Used to have to document on keyboard, but this is our product at Modal where we document by voice. And
77-year-old woman in no acute distress with a history of coronary artery disease, type 2 diabetes, asthma, and hypertension.
I typed
on Altace for 8 years, awoke from sleep around 6 o'clock in the morning, complaining of a sore throat and swelling of the tongue. Period. She came immediately to the emergency department because she was having difficulty swallowing and some trouble breathing due to obstruction caused by the swelling. Period. She has never had a similar reaction ever before, and she did not have any associated
This is a way
chest
better
pain,
way to document
itching,
compared to typing it out. We have a ton of people who think they're much faster at typing than speaking until you actually run them head to head, and then you find out it's not even close. You guys are all probably familiar with Siri now and voice in, voice out interfaces, but 12 years before that, we actually thought changing from voice to visual, changing from visual, I should say, you know, what you see on the screen, to voice in, voice out, we thought would be pretty cool. So to prove that I actually beat Siri on this by 10 years, you can see that I'm a lot younger in this video. No gray hair, no wrinkles.
Hallie,
Yes, John?
tell me about room 3, please.
Okay. John Smith is the 45-year-old male in room 3. He has been here 12 times, the last being 8 days ago, at that time with a complaint of stomach ache, and today is here with a complaint of abdominal pain. Triage category red. Request completed.
So you saw I had a tracking system that I wrote, right? So I actually tied that into the tracking system. I'm going to skip the next video. I actually put this thing on my head because we didn't have mobile phones at the time. I actually put that thing on my head, and I walked around the emergency department treating patients and talking to my computer with this contraption on my head. And the residents and the other doctors and the patients thought I was crazy, but it totally worked, and it was really cool. And I wish I had a picture of me wearing it, but I don't. But actually now bringing it forward to the modern day, we do have modern devices with voice in, voice out capability. And so now we can actually be totally mobile. And this is a product that we're doing in partnership with Intermountain that allows us to do voice-based order entry of medications. So here we are looking at the app. Let's say that I'm out and about. I'm in my car. I'm a physician. I'm in my car. I'm walking the halls of the hospital. Suddenly I get a call. There's a patient who has just had a procedure. The patient has some mild pain. They want to order maybe some Tylenol or some Advil or something like that. Mm-hmm. So normally I could do a verbal order and then hope they don't mistranscribe it. I can hope that they don't. I can hope that, I can wait till I get to a computer and hope I don't forget to do it. Mm-hmm. Or I can just pull up my phone or my iPad mini and I can do the order by voice in this way. So I have a list of my patients. I can select the patient. In the future, we'll probably offer the ability to, select the patient by voice. But I'll say, okay, Elizabeth Blue. I just hit the record button. Tylenol, 650 milligrams, PO, Q4 to 6 hours, PRN, pain or fever. And there it is. Perfect recognition. It got Tylenol, but you'll notice that it converted it to acetaminophen. It's 10 times. Later in the video, I actually do it by hand. And you see, even for a simple touchscreen interface, that I could do 3 to 5 orders by hand, by voice, compared to how quickly I can do it by voice. We actually have done some things that didn't work. We tried Modality Change, saying, hey, instead of doing reality, what if we had a virtual reality sort of an environment? So this was, believe me, state of the art back in 2004 when we did this. How many of you have ever heard of the video game Quake? So the original Quake engine, not Quake 2 or Quake 3. We used the original video game engine of Quake to make a video game-based electronic health record. And this is that record. You could literally fly around the emergency department. This is a real-time view of what the emergency department looked like inside. These are patients in each one of these things, and there's little icons over their head. You could fly into a room, and if you saw X-ray or med or past medical history, you can click on the icon, and the X-ray would show up. And it turned out that was actually cool, but not that useful. It was just a lot of extra navigation for no real benefit. But the good news is when you try something crazy like that, you do learn and find out, well, where would this thing be useful? So one of the things we did was a modality change with even before Connect happened. So actually, we did this years before Connect. If you guys are familiar with the Connect on the Xbox, gesture recognition and stuff. They actually, at Microsoft, stole my developer to work on the Connect project. So, but we said, hey, what happens when you're gowned and gloved and sterile in the operating room, and now you need to look at the CAT scan or the MRI to see what what's going on. And we said maybe gesture recognition would be good for that, but manipulating an EHR that was designed by mouse isn't really good for that. So what we actually did was we put the X-rays into a virtual reality environment and then used your hand to manipulate that virtual reality environment, and it worked really, really great. So even when we've made mistakes and things have failed, we learned from that and applied them in new and different ways. This is actually a real patient. There's a real patient somewhere in there where her head is actually open, and the neurosurgeon was digging around trying to find where those tumors are, those big white spots in the brain, and he needed to stop and go look, and he was testing our thing out. See all those other people there? It's a little hard to see. There's a whole bunch of other people there. You know who they are? All the other surgeons from all the other operating rooms left their patients open on the table and came in there to see this because it was so cool. So, and that really, really, really did feel like magic. How else to automate everything? You can reassign the work. It feels like magic if you don't do it and somebody else does the work for you. So here's one where we have transcriptionists do the work. This is a thing we have called Fluency Flex, where you can dictate and speech recognize it. It will automatically create all the text for you. But then you have to go through and you have to correct it if it's made any mistakes. Well, what if you don't want to correct it and you don't want to make, there's mistakes in there, but you don't want to correct the mistakes that happen in the speech recognition? This little tiny magical button right here where the arrow is says send to the transcriptionist. You click it, goes to the transcriptionist, they'll correct it for you, send it back into your EHR. Feels like magic because, yes, a human did it, but it wasn't you, so who cares? Right? Really, really great. Similarly, let's put our patients to work and say, well, it feels like magic to me if all the medications or allergies are already in the record, and I wasn't the one who had to enter them. So here's an example. I'm not affiliated with these guys, but of a website where patients can go. They can enter their allergies, their medications, their prior problems, their review of systems, and it automatically uploads into the electronic health record, and then the clinician and the actual visit can affirm or confirm or deny each of these things. And when the patient does it, it feels like magic because the main thing is it saves me time. I don't have to do that work. Utilize ambience. So this is like what we have at the airport where you don't have to log in or do anything. The displays about when your flight is leaving and if it's late or not are just sort of there on the walls, and you can just see them. So we've done the same thing with stuff like contaminated culture reduction. So when you get a blood culture, if you don't clean the area well enough, then it looks like there's an infection, but it's really just because you've got stuff from the skin on there. It means the phlebotomist or the nurse or the doctor did a bad job in cleaning. It's responsible for a lot of money and a lot of extra days spent in the hospital. So we put up a graph of each phlebotomist and how many contaminated cultures they had in their workroom. And guess what? Nothing else. It all got better, right? Everyone could see that this guy right here was the worst phlebotomist in terms of that problem. And we didn't have to do anything more than just put the data up on the wall and show it every single day, and it just went better all by itself, called the Hawthorne Effect. Same thing with self-pay over 65. No patient really in the United States, unless they're from out of the country or something, should be self-pay over 65 because we have a thing in this country called Medicare, right? And most of the time when it's a self-pay over 65, what that means is the registration clerk didn't do their job, right? They should have, they just said self-pay instead of asking the patient, do you have Medicare? Can I have your Medicare number? It's bad for the patient because then they get a bill for a whole lot of money, and it's bad for us because they never pay that bill. So what we did was we put the name of the registration clerk in every single patient that was self-paying. We just put that up on the wall where the registration clerks work, and guess what? That thing just went away, right? Because nobody wants to be there knowing that everyone can see they're not doing their job. This is an orb that I tied to the how busy the emergency department was in my tracking system. I actually had it in my house. It would be blue if there was, not a lot of people, yellow if there was a lot of people, and red if it got really bad. And literally one day I'm working in the emergency department, and there was some huge accident, a school bus, and a ton of people came in, and my wife calls me up 1 second later and goes, is everything okay? Your orb just turned red. That's magic, right? No work whatsoever, and everyone can just see what's going on. And then this is ambient display as well. I'm documenting, and we use natural language processing to see that you're talking about congestive heart failure, but you haven't documented it correctly. And FYI that, hey, by the way, you stopped, Lasix 10 days ago. Maybe that has part of the problem. And you use CC, which Joint Commission says is a dangerous abbreviation. Maybe you should use milliliters. Automatically pull the medical history from the records that we already have and show that for context. So these are ambient displays that just show non-interruptively to help me do a better job without doing any real extra work. And then finally, the ultimate is auto-populating data. Nobody wants to enter in a login and a password, so we put in iris scanners and make it down like that. And then we thought bending down is still too hard. So we created facial recognition software. Here you can actually see somebody sit down, and they don't type anything. The system just starts logging them in. Next guy's even faster. He sits down. He's going to type in his ID, but it's already logged him in, and he's super happy, right? To him, this is as magic gets. Tracking board. Instead of having the nurses enter, the patient's in room 1 now, the patient's in room 3 now. We actually put RFID tags on the patients, and then we can actually follow the patients as they go from room to room. So now nobody has to enter that data. BMI. So if you want to do a body mass index, which is a sign of an important thing for your health, you need the height and the weight. So we put a scale on the floor, and as you walked in, we automatically captured your weight. But what about the height? So we actually put an ultrasonic transducer up on the ceiling. And when you walked under, the ultrasonic transducer would measure the distance and calculate your height. And you can see me actually gaming the system, trying to be a little taller. And then we auto-entered that into the system. And then finally, the ultimate is auto-populating documentation. Well, we already know stuff that's in the record, so we'll just use that to auto-populate what's already there. That you have shortness of breath. That we think it might be due to the Lasix that we already knew was stopped a few days ago. Auto-import the vitals from the nurse and auto-generate an assessment and plan. And I can delete this if it's not right, but, then everything feels like magic. That's where we're ultimately hoping to get to. So we've talked about creating magic, save time by automating everything, and automating everything by turbocharging your systems, pre-processing the content, anticipating the needs, varying data types, change all these things. And those are the high-level things. Now I would put together a video of the future and how I think this all comes together. But I'm not going to do that. Why? Because I want you guys to go and invent the future. I've given you the principles on how to do it. Go out there and make something cool, and don't listen to some old fuddy-duddy like me tell you what to do. Go do something cool for yourself. And along those lines, I want to introduce Lynn and Dan, who are going to talk to you about how they take these principles and then find new ideas and harvest them in really tangible ways in order to create new and cool things. So there you go. I think you have that. I'm sorry. Yeah. Yes.
It's on. Okay. Can you hear me? Yeah. Okay, great. My name is Lynn Koseki. I'm the Director of Solutions Realization for Modal. My team and I are the ones who go out and work with folks like you, with our provider partners. Folks like Dan, they follow doctors around, they follow HIM personnel around, and we document workflows. We try to find the pain points. We try to figure out how can we help each other, how can we work together. So we have a program at Modal that we call the Lighthouse program, so use your imagination. So a lot of people will say, they'll look at this picture and they'll say, well, why are you looking down into the fiery depths of hell if it's supposed to be a good thing? So I say, no, you have to turn your eyes around. You're looking up at the light in a lighthouse. And the reason we call it this program, the Lighthouse program, is because we work with a handful of select healthcare providers, organizations such as yourselves here, and because these are the folks who are already a couple of years out ahead of the rest of the industry. These are the folks that are already facing the challenges. So these are the people that, working with them, we hope to be able to kind of light the path for the rest of healthcare. Hokey as it may sound, but it's fun. So Dr. Handler was just talking a little bit ago about some documentation challenges. So in healthcare today, what do doctors and healthcare organizations get paid to do? Anybody? What do they get paid to do? To document. Oh gosh, usually people don't fall for that. So they don't get paid to see patients, and they don't get paid to care for patients. They get paid to document, because if it's not documented, it wasn't done. And if it's not documented well, and if it's not documented accurately, then no one has the correct picture of what's actually going on with the individual patients and what's actually going on with the entire population. And right now, particularly as we're moving towards value-based healthcare, value-based reimbursement, this is more and more important that we have an idea of the actual health of the population so that the healthcare is reimbursed adequately. So towards that end, somebody somewhere along the line decided that the best way to document for patient care is in structured data so that we can reuse that data downstream for lots of different purposes. And that makes absolute sense. Unfortunately, they also decided that the best way to capture this information discreetly such that it can be understood by computer systems downstream, it can be analyzed and reused, is to create a whole bunch of check boxes and structured text fields and to force doctors to spend a whole lot of time pointing, clicking, pointing, clicking, pointing, and clicking. So this is the type of thing that we hear from HIM professionals in the organizations where we go. We hear that the notes are redundant because physicians, in an attempt to save time, are doing lots and lots of copying and pasting. And oftentimes the information is redundant, sometimes even incorrect, causes lots of problems. The residents are text messaging. So some of the younger doctors coming into the health systems are accustomed to IMing, they're accustomed to text messaging, they're making up their own abbreviations. So we all know there's the Joint Commission is out there, and they have a list of do not use abbreviations. That's an old school list. That was created back in the days of handwritten documentation. And they came up with this list of do not use abbreviations because they're the ones that, if written in handwriting, could be misconstrued, misinterpreted to be something else. The really dangerous abbreviations that are being used right now are the ones that doctors, in an attempt to save time, are making up on the fly. Everybody knows about the Joint Commission do not use list. Everybody knows what they are. But you don't know. We've seen some incidents, and Dan's going to talk about this later, where doctors are actually doing this N/V/whatever/whatever/whatever, up to 8 characters long, and then someone else is supposed to know what that means. So the doctors won't use it. Documentation modules in the EHR, even in places where the other modules of the EHR are well adopted, the documentation modules are actually very poorly adopted. The doctors that we talk to say, I can't see the patient story. I've got all of this information at my fingertips, but I can't actually see what's going on with the patient. They say, I can't tell what's new. I can't tell what's changed between yesterday and today. They tell us, I can't tell how the patient feels. I've got all their vitals, I've got all their labs, but there's nothing in that electronic health record that tells me how that patient feels today compared to how they felt yesterday. I see 2 fewer patients every day now because it takes me too long to document. Or they say they save all of their documentation for when they go home or on the weekend because they just don't have time to do it. It takes so long. So, and this one, I'm undercoding and I'm underbilling. Because of the way that they're capturing information, they're not necessarily sure that they're capturing it correctly, and because they're afraid of audits, they're afraid of being caught overcoding and overbilling, they're actually, a lot of them that we hear are purposely undercoding and underbilling. This could mean a big loss in revenue for any healthcare system. And unfortunately, we'd all like to say that we're all here to keep people well, but healthcare doesn't happen without money, so that's a pretty important one. So, our Lighthouse program, why do we do it? To inspire innovation. At Modal, we have lots and lots of ideas, lots and lots of smart people, but where we're really going to learn which ideas are very useful, where we're really going to source these ideas is through these healthcare provider partners. It teaches us how to better serve healthcare, and most importantly, hopefully we can create the tools to help to bring other healthcare institutions, the smaller community hospitals, into the realm of the Lighthouse type providers. So who is the Lighthouse? So it's a limited number of customers that we work with and we actually co-develop with. Right now it includes the Mayo Clinic, Geisinger Health System in Pennsylvania, University of California, Irvine. We were just up at Beth Israel Deaconess last week talking to them about some challenges. I'm just going to talk a little bit about some of the things that we've heard from a couple of these partners and how do we kind of get started? How do we figure out what we want to work on together? How do we figure out what's of benefit, what's of value to healthcare providers? So this is one of my very favorite statements that I've ever come across, and this is from a Dr. Ken Wood. He's the Chief Medical Officer at the Geisinger Medical Center, the Geisinger Health System in Danville, Pennsylvania. And he says, documentation is the process by which we crystallize what's going on with the patient. So the first time we met with him in his office, he's ex-Marine, right? So he's got the shiniest, sparklingest office you ever saw. So you're kind of afraid to touch anything because you might smudge, right? So, but he's got this big bank of metal file cabinets because even though he's fully electronic, they use Epic there, he's fully adopted, he's pretty convinced that someday when something happens and all connectivity's shut down and all the electricity's gone, gosh darn, he's got his paper. So, but it's pretty funny because he walked over to a file cabinet, one of these drawers one day, and the drawer was actually labeled very, very beautifully stuff. So he opened his stuff drawer and he pulled out some examples of documentation and he showed us what he considers to be useful documentation. Now this is copies of paper and this is the way he documents, and because he's ex-Marine, his documentation is perfect, right? So what he would have at the top of every paper is a diagram, and he would start with the principal diagnosis. He worked in he was the head of the ICU, and then he would break it down into the ancillary diagnoses, the contributing factors, so that anyone who picked up that patient's chart could get a really quick snapshot, a really quick picture of what's going on with that patient. And then underneath that, in very neat military script, he also spelled out more information and narrative about all of those conditions, about what was going on with the patient. Dr. Wood was unique. You saw Dr. Handler's documentation earlier. Not quite so neat. Most of the doctors I've run across, their handwriting looks a little more like Dr. Handler's. Dr. Wood's actually the only one I've ever seen that looked like Dr. Wood's. But his point is, though, that an EHR is set up in a very linear process. If you want to see labs, you click here. If you want to see allergies, you click here. It's 1, 2, 3. Doctors think in parallel. They think of all of these things at the same time so that they can understand, so that they can initiate their thought process, initiate the care process about these patients. Dr. Wood says that the way doctors used to document, they actually use the documentation process to crystallize what's going on with that patient. Now they're forced to conform to a template. So now their thought processes are forced to conform to the EHR and not the other way around. Dr. Wood's challenge, help me to create a system that I can use for documentation, that helps me to crystallize what's going on with the patient, that correctly captures, and he used this phrase, the exquisite care that we provide to our patients and which helps my doctors to do it quickly and efficiently. Easy, right? Problem solved. Not so much. Okay, so this is out at Mayo Clinic, and this is in Rochester, Minnesota. And we worked there. We've been working with them for a couple of years now. They still have in-house transcriptionists, a whole lot of transcription going on there. They have the best partnership between medical transcription and electronic health record and physicians that I have ever seen anywhere, bar none. So Mayo has one of the original CDA-based, clinical document architecture-based systems out there. So they're capturing all of the information electronically. Their physicians dictate, and their medical transcriptionists have to turn that information around really, really quickly because very much like your facility, Mayo Clinic is a destination healthcare. A lot of the patients come from elsewhere. They're staying there for a couple of days. So they're seeing a number of specialists in the course of a day, and based on what that first doctor says, they may have another appointment in 4 hours. They may have another appointment in 45 minutes. So that documentation has to be turned around like that. So those transcriptionists really have to be up there. But what those transcriptionists are also doing, besides just creating a document, is because they're working in this CDA-based editor, as they edit the speech-recognized content that we produce, they're actually validating the electronic structure of that documentation so that they don't know they are, but they are because of the way the system's set up. They're actually helping the doctor to reconcile the patient problem list, the allergies, the medications. And they've been doing this for 15 years, long before meaningful use was even a gleam in Dr. John Halumka's eye. So that was something that we learned there. is that sometimes there are things going on and the user doesn't even know what they're doing, but they're actually doing something very important. What our team does then, and what all of you should do if you're looking for solutions to problems, is a lot of times folks think, oh, okay, so to find a problem and to find how to solve it, listen to the people, listen to what the problems are, listen to why they don't use it. We turn around and we say, no, let's talk to the people who are making it work. Let's figure out where they're using sticky notes and duct tape to hold things together so that we can automate that sticky notes and duct tape and figure out how to fill those gaps. So our methods, we create very high-touch relationships with our provider partners so that we can kind of create the champions to create adoption and to create a bond that survives challenges. When you're working with new software, the first iterations of it, it's going to suck. It always does, right? But you've got to start somewhere. We believe in putting something out fast, getting it out in front of users, getting feedback on it. If it's going to fail, we want it to fail fast so we can iterate, get the next version out, collect more feedback until you get something useful. Otherwise, you can sit and, if you go through a more traditional method, collect requirements, collect requirements, collect requirements. You can still be collecting requirements. Somebody has been through this. So you can be collecting requirements for the next 2 years and never come out with anything that's actually useful. So we work together with our partners to observe what's going on, to hypothesize about what a solution might be, to experiment, to fail and fail fast, to iterate, do it all over again until you actually come up with something useful. So, and that's our team right there. That's Dan in the orange. He's going to kill me later for saying that. So no, that's you. I'm not in there. Okay, so and now I'm going to actually hand it over to Dan. Dan is my team lead on my team, and he's just going to tell you about a day in the life of a solutions analyst. This is how we work.
So I think we have a couple minutes left. I'll go quickly through this, not super interesting, so we can have questions and discussion. But like Lynn said, we do a high-touch relationship. We do workflow observations. We document, look for the sticky notes and duct tape, and work with the people who are making things work, even though they're not great and they suck. And they also, we compare that to the ones who are complaining and not using it. Advanced slides here. So while this is a fun, meet and greet and get to know each other visit, this is a day at Geisinger Hospital, which was kind of a crazy day where I had to wear a lot of hats and work on a lot of different projects all at once. So this is kind of typical for a visit where you're going and actually getting really deep into these projects and understanding. So the day started early with a meeting with the steering committee for these projects overall that we're calling closed-loop documentation, where we're doing some of the things that Dr. Handler spoke about, automating tasks and bringing data out of the buried EHR to bring it to point of care to help improve documentation processes, make it more efficient, and work smart where we can. So this was just the overall steering committee. We had to do some demonstrations, report on progress. Easy start to the day. Actually, that was probably the hardest part of the day. So the rest of the morning was spent observing rounds. This was probably my favorite part of the day because I really enjoy watching patient care. I like seeing how the people use their systems. And I'll share one really interesting observation. This group of residents I shadowed were going around and they were in the ICU. One patient they spoke to was in pretty critical care. He was very unaware of where he was. He didn't know who the president was. And instead of looking up in the record who his cardiologist was and when his heart surgery was, they asked this confused patient. I asked the resident later, why did you ask him? Why didn't you just look it up? And because there was a chance that this confused patient would remember it. And it was easier than finding it in the system. And that just kind of floored me. I was very surprised by that. So that was interesting. I take a lot of notes. I think later there's an example of a workflow diagram, and you'll see this is what the person in charge of the department will say is the process. This is what actually happens. This is what's supposed to happen. So that's the fun part. Lunch if we have time. And then I did some shadowing. There were some doctors that were using some of our speech software that Dr. Handler demoed before. And I got to do some observation, to be a fly in the room while they document, look for gaps in that process, understand where we can use voice commands and replacement rules to make things easier, streamline the documentation process, make it as seamless as possible for them. We also use that to build more workflow diagrams to understand when they document, where they document, what information do they need at the point of care that we would use text mining and want to pull out of the system for. So it all comes together. I also met with the Chief of Radiology, who's a champion for our Catalyst projects, which is our natural language processing and text mining application. So we're working with him, I'll show another slide later, trying to identify who their real AAA abdominal aortic aneurysm patients are. According to their billing codes and the structured data in the EMR, they have, I think, around 1,000. And throughout this project, we found by mining the narrative that they have almost 2,000 to 3,000 patients with AAA. So we were able to find that real population, and we want to even take it a step further to try to bring that recognition of a AAA patient by the narrative to the point of care and ask the radiologist, could you please initiate follow-up or make sure that this ends up on the right list so that we can follow up with those patients later. Last but not least, the clinical innovations team, I had a meeting with them, and they're the ones who actually we work closest with and that set us up with the radiologists and the physicians using our speech software and the governance committees. They're the ones that are the foot in the door to help coordinate these activities. So that was a mostly planning session, digesting the day, and then last but not least, I have to finish up my work, do some diagramming, get my notes out of my paper notebook so I don't forget it or I'll never do it again. And eventually it's time for a dinner and a beer because there's another day. Usually these trips are 2 or 3 days. So there's a nice little brew pub in Danville, PA, quaint little town if you're ever in rural Pennsylvania. I think there's some examples and we'll finish up so we have questions. No, not examples. We can talk about that later. But, so this top picture is what's supposed to happen. That's the full detailed process for problem list management to trigger appropriate risk levels for patients so that they're in the right risk profiles and they get reimbursed the right levels for them. The bottom left is the simple part of it, what's supposed to happen. They're supposed to update their encounter list so that it triggers the right claim and they get the right risk adjustment level. And they're also supposed to update the problem list to trigger their care gap management program, initiate some of these closed-loop documentation processes. But what really happens is they update the encounter list with an unspecific condition so that it doesn't get the right risk captured, and then they don't go to the problem list because it's extra clicks, and they already updated one list, so they're not going to update a second list, and then they end up with poor risk levels that doesn't trigger their care gap management programs. And so we're looking how we can mine old data to update the problem list, make sure it's reconciled, make sure it has the most specific conditions. This is examples of what we did with the AAA project. Again, we mined the narrative of reports to find all the incidental findings from the radiology studies, not just the ones that had a billing code of abdominal aortic aneurysm. And then we also risk stratified them by understanding what is the size of that aneurysm. So here's all your aneurysm patients. There's 3,000. You thought you only had 1,500, but also these are the ones that have aneurysms that are greater than 5 centimeters. They probably should have seen vascular surgery a month ago. And this is an example, a screenshot of what our system looks like. It's de-identified, but this is where we could see where we're identifying in the narrative that this was an aneurysm and it measured 5 centimeters in maximal diameter. Lynn mentioned the Danish abbreviation project. This is, again, something that Geisinger spends a lot of time manually reviewing documentation, looking for presence of these abbreviations, because if they find it before the Joint Commission does, they can correct the action with the doctors and notify their departments. If the Joint Commission finds it, they're going to slap them on the wrist and take money away from them. So we found out, though, that this manual review process took about 30 hours a month to review 5 to 10% of their documentation. So we did a side-by-side comparison using our software, and we tried to we improved that process down to about 5 to 8 hours, and now we're working on scaling it up to do more than 10% review. Yeah. So, John, you want to wrap up?
So we'll end it there and say we've given you we've given you the principles on which to create magic. We've given you the workflow on how to actually go out and harvest new ideas for creating magic. And so this is an awesome, world-famous informatics center. So I'm looking forward to seeing you guys go out and do it and hopefully send us a note about something cool that you've done. Thanks so much.
And let me just ask, for those who don't know, if when you talk to push, like I'm pushing on the button here, mostly so it'll be recorded on the videotape so the people that are listening can hear it. Since I'm pushing the button, I will ask the first question. A lot of these interface things are really cool, and they all the principles kind of resonate with me. We sort of have this problem in health IT. It's a generic, maybe epic kind of problem in terms of implementing these sorts of things. I think you know what I'm getting at. I should explain for those who don't know. There's a system that has a large share of the marketplace called Epic. That's a very kind of closed system in terms of its interface. How do you work with Epic customers, and if so, how are you able to kind of get into the guts of things to be able to implement some of these obviously efficient things? Can I see you to push
and you did say to do that too. So one mouse click.
It's a poor interface.
So we kind of attack it on two levels. So we do have conversations going with Epic all the time, and they're very interested in working with us. But because they're pretty busy these days because of meaningful use and other things that are going on. So in order to get some of our work with them prioritized more highly on their list of things to do, more pressure on them from their customers is always key. So we have some key provider partners who are Epic customers and who are kind of asking Epic, hey, we want you to integrate more closely with Modal. So, but we also have to assume that even if Epic says yes, there's a whole lot of other EHRs that may not, or they may not yet. And also, even if they say yes today, it's going to take time to actually get it out there. So we also need to make sure that there are a number of things that we can do kind of on top and beside it without necessarily having to have a deep integration. So
yeah, I agree. We've got a lot of integration with Epic. Some of our best integrations are done with Epic, and there's some things that we want to be able to do that can't do it. That I can't put this thing in there, right? I don't own that or control that code. So then the question is, what are my options? My option number one is I'll put my own window up there, which I actually showed an example of that. Our product that's coming out soon called, I think in next month or so, called Echo. Well, code name Echo. We don't actually, coming out in a month, we don't have a name for it yet. But I should, the ambient window that is just sort of showing, and as you type or you speak, we're recognizing the natural and understanding the natural language that you spoke or typed, and then we're actually putting up information that might be of use to you because this is what you said. Well, they don't have a place for me to put that right now, so we created our own window and float that over. I think for all these sorts of things, you've got two paths. One path is to find a workaround, and the other path is to try and make it happen. Three paths, try and make it happen. But there is a third path, and the third path is to say, there's a million problems in the world to solve. And if this one proves to just be way too hard to take one of those two paths, I'll just not solve that problem, and I'll pick a different one instead. And I think the key to the success that I've seen has been not getting married to the problem. There's enough problems that you don't have to pick one and get married to it. Instead, say, what assets do I have? What things can I do relatively straightforward fashion? And what problems, of the million problems that exist in the world, what problems can I solve with the assets that I have? And that has made all the difference, really, in the world in terms of where we found success. There's a million things we wanted to do that were just impossible. And yet when I show the things we did do, they look like that was amazing. And why? Because we could do those, and I'm not talking about the other 800,000 problems we couldn't solve. Yes.
Hi, my name is Vinny. Sorry, thank you. I'm an informatics student here. My question is regarding the SARS example that you said. The temperature above 100 should be recorded. Why? Sometimes we can have that as a trigger, right? Something which has to be mandatorily filled in before you can proceed further with the workflow. Mm-hmm. My question is what's the maximum limit of those mandatory fields that we can have per encounter before the fatigue sets in?
One. it's so easy to get carried away with these. You can't proceed to the next thing until it's mandatory. You put one of those things in there, and your users will be pulling their hair out going, and this is why I liked paper, because that didn't exist for paper. And I think the key questions that come to my mind are why, question number one is, do I even have to make the doctor capture this? Is it already existing somewhere else and I simply am failing to reuse the information that's already there? Is there somebody else that could do this work besides this one person that's like super overworked already? Is there some way that I can infer this or capture this automatically? If I can't do that, then my next question is, how important is this thing really? Because there is an opportunity cost for every single thing you force somebody to do, and it's easy to just imagine that the time is this infinitely expensible thing, but it's not. And so the minute that if their natural reaction, you're putting in a mandatory thing because their natural behavior is not to do the thing that you want them to do, right? They think there's something more important that they should be doing. You can put in an infinite number of mandatory things as long as for every one of those things you put in, you take one or two other things out that then balances out their time appropriately. If you want me to spend the next 10 minutes doing nothing but filling out a form, I will happily do it as long as you take 10 minutes, or better yet, 15 minutes away from other activities that I would otherwise have to do, so that I perceive this thing as a net time savings. And so my answer to you is to look at the entire process and say, I need to come out net zero at least, preferably net negative in terms of time, net good in terms of time savings. And you can look at all the processes they have and say, I'm going to make this thing 5 minutes worse, but in return I'm going to make this thing 10 minutes better. Not this thing next week 10 minutes better, this thing right now 10 minutes better. And when you do that, you can get away with a whole lot more. So my answer to you would be the least possible, preferably zero. And if you feel like you have to put them in there, then you should feel the same onus and the same responsibility to take something else out. The mere fact you're making it mandatory means the user has already decided that they have other activities that they think are more important than your activity. So you got to figure out a way around that.
So you had two principles that I found interesting. One was anticipating the user's need, and the other was showing data in aggregate. But sometimes you might not be able to anticipate the user's name. So my question is, have you thought about developing interfaces that allow users to create their own presentation of the data?
Yes. No, but you're starting me on one of my favorite topics. At my last position, we created this thing that was built all around that and entirely around that as an idea. That probably 90 to 95% of users won't ever create anything. Whatever you stick in front of them, they'll either complain or they'll do it or they'll find a workaround, but they're not going to go invent something. However, everywhere you look, in every facet of life, there is the 5 to 10% of people that I call the activists. They can't stand anything not being, optimized, and nothing in the world will stop them from trying to make it better, right? And so those are the people. You don't know who they are, you don't know where they are, but every single department head knows who they are. They're the person that's sort of making their life miserable all the time, constantly complaining or thinking out of the box. Or maybe they're their star person, right? That's the guy I'm going to hire, out of their competency, promote out of their competency because they created this thing sort of on the side and it was a big success, right? Everyone knows who these people are. It's hard for leadership to find them, but if you go and talk on the ground, everyone knows, you want to talk to so-and-so. And so we made an entire system that was optimized to that, to leverage those people. And what happened was we found that most of our customers did not believe those people existed. We couldn't convince them that those people existed. They couldn't even begin to get comfortable with the idea of empowering those people to actually go ahead and create a better workflow for themselves. They really believed in that really top-heavy, let's get all the requirements and let's get, IT and the CEO and the COO involved and we'll have a big committee, right? And so to design one little thing became 3 years long, right? And so we actually couldn't actually get people to deploy it and use it the way that we had spoken about. But on the other hand, we did deploy it at the place where the system was born, and we had all the success that we had was because we, in fact, did do exactly that. We just enabled what was functionally a tool set to let people say, I want this column, I want that column, I want this column, I want that column, I want to order them this way, and I want them this wide, and I don't want the column that says length, the date of birth. I want the column that says the age, and the ability to create new ones on the fly and to make that really, really easy. To say only show me the patients that have been here for too long, or only show me the right, and to make their own work lists was incredibly powerful. So the answer is yes, I've thought of it. Yes, I think it's awesome. Yes, I built an entire product around it, and it was really, really successful until we got it into the hands of the broader populace, who sort of freaked out when they said, we're not comfortable letting real people do this. But in fact, it's that attitude that is the reason why so many places are having so much difficulty in getting to success.
Those couple of slides that Dan showed for the dangerous abbreviations in the AAA, that particular interface right there is all configurable. So Dan's background is health information systems, HIM. He's not a programmer, but he created all of those layouts. So that interface, we purposely designed that way so that you can change the displays and to allow someone who's not an engineer, not technical, to go in and kind of write queries against the NLP to answer those questions themselves. So, and understanding that, to Dr. Handler's point, the majority of people are going to want you to give that to them, and they'll click the button and then run the numbers, right? But there is that small subset out there that want to do it for themselves, and they want to say, well, you know what, great, you're showing me AAA, but I want to know about something else. So that gives them the ability to go in there and do it as well. So I agree, it's really important.
That was what attracted me to go to Modal. Was I saw what we were doing, and I said, same idea now with unstructured data, and it was really fascinating and really awesome. And so yeah, I agree, very, very powerful concept. And the key is having the guts to let, actually leverage that. You have to believe in, if you don't believe in crowdsourcing, then you won't believe in this. If you believe in crowdsourcing, which you should, because like so much of the world runs on that now, you can get some really amazing things done.
Good. I want to thank our speakers.